First of all, I would like to thank Senator Alberta Ferretto and Senator Max Romero, who is following us from the screen. And it was him who brought me and Professor Cavanna to the Ministry of Health 6 months ago to talk about the fact that there are therapies. And we mentioned it with Professor Sileri. And he said, I know. And I mentioned a gene that puts COVID at risk, turning people that have one or more genes that allow for a higher risk of contracting the virus, one of which is an HLA401. And he said, I know. And he gave us a paper about this specific gene dating back to 2020, to summer 2020. So I wonder why he doesn't talk to his minister. There was an Italian song, 4 friends at the bar who wanted to change the world. There were just 2 of us, Robert Steiner and me. And we were on Zoom and not at a bar when we decided to imagine the first international COVID summit. I had hundreds of patients, so I said to Robert, well, take care of it. You and Lily, I'm sure you will be perfect for the task. And I thought, well, maybe it's too much for them, but that's not the case. I underestimated you because you really created something incredible. We also had another dream, the creation of an onlus COVID healer to develop an application that could help patients to find treatments and doctors to treat patients with COVID. I imagined myself here, like Steve Jobs, with a turtleneck, with a black turtleneck, presenting it to you. But unfortunately, the App Store needs a lot of time before publishing an app. It proposed to publish the PKA on the Android App Store. Maybe I don't agree with the idea of bringing the global population down by 2 billion people, unlike the heads of the system. So I'd like to mention the app without showing it to you. Because I'm a romantic by heart, and a doctor that likes the old methods. Otherwise, I wouldn't have been able to treat 1,300 patients. I was part of many committees, by the way, but I treated 450 patients in a hospital. I lived there, I treated them, and they all recovered. We didn't record a single death. And to do so, we went against the guidelines. Not so much as go against, but rather we redefined the guidelines, which are too often static, old, maybe drafted by people who have never seen a patient, and that's not good. The app will provide change in this attitude. I'm sorry, in order to be fast, I wrote down everything, and now I lost track.
I'm sorry, Dr. Stremezi is my hermano, my brother in clinical practice, and he kindly asked me to explain in English about this wonderful app, COVID Healer. And I just, on searching a fair Italiani, no, too early? I'll tell you. Okay, I'm sorry.
George Farid is a very generous man. Just think that Once, during a US broadcasting, he defined me as the European Peter McCulloch. And I thank you for this. It's not true, but anyway. I just asked him if he is available for translating the app for the US, because there are completely different prescription rules over there. Now let's get to the app. Next slide, please. Italy was the first Western country to be affected by COVID. So most of us, Mangiagalli, Luigi Cavanna, myself, Freddy Sute, Antonio Palma, among others, I'm sure I'm forgetting most of us, but we went to the patients to visit them, and we were alone. We were the first to do so. We didn't know each other, so we treated them just through the visits, trying to recall the basics of infective diseases. We gave them known and cheap drugs that we knew well and that worked. Then connections with the rest of the world allowed us to get in touch with other doctors and to teach them to treat people just like we were doing in their own countries. Some of these doctors mentioned us, saying, "I've learned how to treat COVID by Milan's doctors." Next, please. Basically, what we did was set up organizations that whose target was to provide solutions to our problems of the time, like Hippocrate.org. Our goal now is to export this initiative, so allowing other countries to use this app to treat patients remotely, regardless of where a doctor is. Next, please. Once the application is working on the two competitors' stores and it will be available for download, the patient will be able to access doctors quickly and simply, just by filling in the city, the data of the patient, weight, height, chronic diseases, and so on. And they may also state a preference of the doctor that might treat them or the organization, and the patients themselves will fill in the medical history. The doctors in the past few years have had the same problem. Long phone calls, videos, emails, texts, WhatsApp, and one simply loses sanity just to have a medical record. And now the app will provide the medical record given by the patient himself without further adieus like "I'm sorry for bothering you" and so on and so forth. The record will be ready before the patient gets sick, and once the patient contracts the illness, they will have to state how many days went by after the swab or close contacts they might have had. They will insert the parameters, a fever, heartbeat rate, saturation, which is crucial at the beginning because it is a marker of the viral's power, and of course saturation once again. The doctor, for a doctor that's used to treating patients, just think about the fact that this summer, during my holidays, I was monitoring 300 patients. And that's because The other committee had closed, and so they were all coming to me, treating 15, 20 new patients every day, monitoring 300 more, and keeping up with texts and emails is a burden. You are constantly answering the phone at any given moment. And the risk is that among those thousands and thousands of texts, you don't know whether or not a patient has a priority. If they need a change of drugs, if they need oxygen, you don't know that unless you open the text. While on the app, a simple badge will state that Mr. John Smith or Mr. Mario Rozzi needs something, and that's crucial. We will not have to read medical records on a daily basis. It will be the app that will tell us that the saturation of patient X has gone down by 3%. And since it will be multilingual, all these parameters will be completely customizable. The doctor will establish the parameters they want to know. The doctor will be able to establish a therapy with specific parameters. And so it will be much easier to treat more and more people than we do now. And there is also, please, next slide. Sorry, Robert, I'm not looking at the slides. There will also be a second important element to keep in mind for a doctor. Please continue with the slides. Our goal since the very beginning, since March, when I tweeted saying I used azithromycin, hydroxychloroquine, and then I started mentioning ivermectin, which I've been using in the past 10 months. I didn't start yesterday. All of us, we were trying to bring in other colleagues. How many colleagues called me saying, Andrea, please teach me how you do it. Hippocrate.org trained many. But if we had a system, a simple, intuitive system to convince goodwill doctors, which are out there, but who are afraid to treat COVID, not like the beginning of the pandemic. Because, listen to me, you don't need full scrubs to treat COVID patients. When I treat a patient, I touch the patient. I touch their body. I try to give them a sense of calm, saying, don't worry, you won't be hospitalized. And that's 15% of the therapy already. Everything goes back to our hands. Let's use our hands. If a patient lives in Barletta and a doctor with the app lives in Barletta, that doctor will be the first to receive the notification. And if that doctor is not available, maybe, like right now, I am treating patients all over the world, in Belgium, in Dubai, in Brazil, besides all the patients in Italy. Our goal is that doctors can treat as many people as possible all over the world. This is the mission of the app. These goodwill doctors will have a mentorship by me, by Peter McCulloch, via the app. The doctor will see the therapy that we would provide in that specific case, with that age, with that comorbidities, chronic diseases, and parameters. The doctor will just need a click and the patient will receive an A5 format recipe, prescription, I'm sorry, to show at the pharmacy and to receive the drugs. As Fabio said just today, and I want to say this publicly because I've been attacked. I've always treated these patients for free. I never accepted any payment by remote patients. The only funds that we want to raise are for organizations and associations, for patients, or for our initiative, COVID Healer. We would like to bring in retired doctors, dentists, like me. I am a dentist. And if I've learned how to treat COVID, that mustn't be so hard after all. I won't repeat the therapeutic scheme. It's the same all over. There are many drugs. There are microbiota drugs. The concept of bacteriophages, viruses. But anyway, the app will have this main function. And there's another element to it that may be the most important. Without needing evidence-based medicine, huge randomized, controlled, double-blind trials, we will have the evidence of the work of molecules, because completely anonymously, through number codes, the doctors who will be regular users, they will subscribe and insert their data. And through these data, we will be able to control the use of Dromexin, for example, which I didn't know. My colleague, Paolo Baron, mentioned it for the first time. He belongs to doctors from Friuli Venezia Giulia. And he assured me, saying that all the doctors will download the app, and he also took part in another summit in Fiumicino that took place yesterday and the day before. And he said, Andrea, do you administer Promexin? Because I know that it prevents the virus from entering the cell. I started experimenting with it, and in the past month and a half, I've noticed that it shortens the evolution of the disease. And we may witness these kind of progresses on thousands of cases. This will be the real evidence. And this is Paolo Baron's dream, which is my dream as well. This mindset, these apps that will provide real-time data, obviously depending on age, sex, conditions, number of days from the beginning of the treatment. All these data are very easy to retrieve today. And my idea is that in the future, all GPs may have access to this data for any disease without having to wait for guidelines from smart brains that maybe have never even visited a patient. Thank you.
So we invite in now Dr. Bruce Patterson.
advance it. Okay. Thank you, organizers of this meeting. It's a real pleasure to be here in Rome. And what I'm going to talk about is going to be very different, yet similar to what previous speakers spoke about. We spoke about many things, including when to treat, how to treat, and how to save lives. And that's what I'm here for as well. But we've developed a number of tools over the last year and a half to help us do that and know exactly where patients are in the spectrum of this very confounding disease. I agree with Paul Merrick and Pierre Corey that it's one of the most complicated diseases we've ever seen. And I started in HIV research in the late 1980s, and I thought that was complicated. I was in China the second week in January 2020, and I had to cancel my trip to Wuhan to meet with a customer because they told me there's an immune virus. And I said, what's an immune virus? And they showed me some early data, and what caught me was this elevation of cytokines, and not any cytokines, but cytokines and chemokines like RANTES. So early on, I called COVID a RANTES disease. RANTES, or CCL5, is the ligand for CCR5, and it controls the movement of immune cells throughout the body. And indeed, I think that's come true, and it's also come true in the context of long COVID, which I will talk about. I also got involved in 3 very large treatment studies in early 2020. And what I found was patients got better, patients survived, patients went home, but their immune systems were nowhere near normal. We were letting people out of the hospital who, by any stretch of the imagination, if they had come to a doctor's office, people would say, you are very, very sick. So I agree with Dr. Corey, who said, we undertreat, 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 okay? But I'll tell you one thing about using CCR5 antagonists in over 700 acute patients. Not a single patient got a blood clot. We saved 58 out of 60 critical patients. We saved 10 patients off of ECMO. We saved patients off of intubation. And here we are, still without an approval on a drug that is very, very effective, or a class of drugs that's very effective, which I will show you. And part of the reason is the fact that because this disease is so complex, coming up with a placebo group to match your treatment group is next to impossible without the proper tools, without the proper biomarkers. At the time, we started with over 150 biomarkers, and I'm going to show you right now where we ended up with the aid of machine learning and artificial intelligence. Next slide. Next slide. So, as we know, long COVID affects as many as 30% of everybody who has COVID. In the United States, that's 40 million people with COVID and 12 million people who may become long haulers. In Italy, it's, I think, 4.2 million people, and about 1.5 million individuals in Italy will become long haulers. This is a grave healthcare and economic emergency that is on par with acute COVID. In fact, when we spoke to, again, congressmen, Department of Defense, think about the effects on the military of having patients who have had long COVID and can't get out of bed, not to mention carry out their duties or go to work. and help the economy. This is going to be with us for years, even if we came up with a solution to acute COVID. And so I'm going to tell you about our program. We have over 10,000 long haulers, 1,000 post-vaccination long haulers. We have greater than 80% treatment success of these individuals. These patients are going from bedridden to back to normal lives in a matter of 6 to 8 weeks. And this similar pathology exists with those who have been post-vaccinated and have long hauler type symptoms 3 and 4 months after vaccination. Next slide. These are the symptoms we've heard about in long COVID. And some have said there may be as many as 200 symptoms. But mostly there's headaches, brain fog, fibromyalgia, shortness of breath, etc. You can see the list here. This is published in Frontiers in Immunology. Long COVID is almost as heterogeneous as acute COVID. And so you must treat on a patient-by-patient basis with precision medicine. When I came back from China, I said to myself, we need to attack COVID like we attack cancer. Because I will tell you, nobody will start cancer therapy, at least in the United States, without knowing every single cancer mutation in that tumor. And for us to even conceive of treating COVID or long COVID without that kind of information on a patient-by-patient basis and base all determinations on their O2 levels and examinations in the hospital is ridiculous given what we've done for cancer. Okay? This is just as complicated as cancer, and it requires just as much information. Next slide. So what do? We took all the severe, all the mild to moderate, acute COVIDs, normals, patients with other immune diseases, and patients with long COVID, and we did an immune profile with markers that we identified during acute COVID, and we put it into a computer and told the computer, choose the most important parameters to distinguish these 4 groups. Then what we said is, okay, can you classify this new group of patients called long haulers? And it did. And that's what you see in yellow. There's 2 cutoffs, one going horizontally, one going vertically. And we developed 2 different scores. We developed a long hauler index, which is interleukin-2 plus interferon gamma over CCL4, a chemokine. And we also developed a severity score for patients with acute COVID. And as you'll notice, all the acute COVIDs fall to the left side of that vertical dotted line, and all the severe acute COVIDs fall above the horizontal dotted line. What's interesting is there's some patients who are categorized in the hospital as mild to moderate who immunologically are severe. I can't impart upon you more information than to say the immunology precedes symptoms. And when we talk about early treatment, predictive modeling is what's going to tell us what patient is going to become severe and which ones aren't. That allows us to triage into certain therapies, but most importantly, from a global perspective, allows us to manage resources. There are some severe patients who are called severe by the classical definitions, hospital-based, that immunologically didn't fall above the horizontal line and were mild to moderate or normal immunologically. Okay, I would say mild to moderate. They could be triaged to home. They don't need to take up a bed in the ICU just because they're categorized as severe by the criteria that a particular hospital uses. Like I said, hospitalization is not a biomarker, okay? And some of the mild to moderates who are severe needed to be treated more aggressively. The other thing is with the long hauler index, it allows us to follow a non-subjective parameter as we treat these individuals. I don't know how many COVID individuals that you've spoken to, or if you've even spoken to a long COVID individual. We've spoken to 10,000, and every single story is different. And subsequent visits, every single story is different. To try and treat based on that would be next to impossible. Next slide. So from the initial study that we published, we demonstrated, excuse me, can I have the other slide, the newer slide set? This is the old, I gave you the newer slide set. The one on the thumb drive? Anyway, go back one slide. So what we did is in long haulers, we said what is causing the vascular inflammation that we saw in the first paper. And the vascular inflammation was identified as having high VEGF, high soluble CD40 ligand, high CCL5. And we said, what's causing this? So we looked in immune cells, and what we found were non-classical monocytes. There's three populations of monocytes in the white blood cells. Non-classical monocytes express high levels of ACE2, but no CCR5. Non-classical monocytes don't express any ACE2, but express CCR5, and they express the fractalkine receptor. Many of you are asking, what's the fractalkine receptor? It's a receptor for endothelial cells of blood vessels. Okay? We've heard all day about clotting. Clotting is caused by this vascular inflammation. Relieve the inflammation, you don't have clotting. They don't need heparin and Xarelto and all these very expensive anticoagulants. What they need is to relieve the vascular inflammation. So what we did is we sorted these non-classical monocytes where we found the S1 protein of SARS-CoV-2 17 months after infection. These cells have no SARS-CoV-2 RNA. This discovery of pathogen protein in cells in the absence of pathogen nucleic acids is a completely new concept, similar to prions compared to viruses. What we're seeing is persistent antigenemia in long COVID in the absence of viral replication that's making long COVID individuals think that they have the infection still when they don't. So our job is to treat the immunology because there's no virus to treat. Okay? And that's what we did. We also sorted the cells that contained the S1 protein, and we did whole genome sequencing of the SARS-CoV-2 virus in these cells, only remnants of small viral fragments of RNA. But this mass spectrometry image showed that single spike of the S1 protein in every single long hauler that we looked at. Okay? Because this is the older slide set, we did the exact same thing in post-vaccination long haulers. They have the exact same persistent S1 protein stimulating their immune system, even though they've never been infected. Okay? There's a similar mechanism in Lyme. There's a similar mechanism in some other diseases like MECFS. So we've expanded our program from long COVID to post-Lyme, MECFS, and other immune disorders. Next slide. So what does this do? This was truly remarkable. This cell type has a propensity for blood vessels. So it's carrying S1 protein to the blood vessels 17 months after their COVID infection. These cells bind via the fractalkine receptor to a protein called fractalkine expressed on the endothelial cells. Long COVID is endotheliitis. You treat it, they get better. You treat post-vax with the same treatment that I'm going to show you, they get better. But the symptoms are angiogenesis, which increases VEGF, which causes peripheral neuropathy, and vasodilatation, which gives them the head fullness, brain fog, tinnitus or ringing in the ears, headaches, and migraines. So you treat it with a combination of CCR5 antagonists, which keep those cells from migrating all over the body, and statins block the interaction between fractalkine and the fractalkine receptor. Okay? Treat 8,000 patients. 85 to 90% of them get better. It's been fantastic. And that same protocol, which is on the other slide deck I gave in this morning. Next slide. Next slide. Yeah, it doesn't have the treatment regimen. We use a combination of ivermectin, 6 to 12 milligrams every 3 days, so just a little bit. Maraviroc or Cellzentry, which is a CCR5 antagonist, 300 milligrams twice a day, and Prevestatin, 10 milligrams a day, which block the cause of long COVID. But I'll tell you, we've been giving that to patients who have symptoms, the first sign of symptoms in acute COVID, and they respond in 2 to 3 days. Just those 3 drugs. Because what you're doing is you're preventing the virus from doing what it wants to do, which is cause blood vessel inflammation, which of course leads to the clotting. Like I said, over 700 patients, not a single blood clot in the acute trials with CCR5 antagonists. You can see the long hauler indices are circled in red in these 2 patients. All the cytokines come down, VEGF, IL-2 with Maraviroc therapy. Long hauler index from 4 to 0.3, from 11 to 1.3. These therapies work, and we actually have metrics that tell you they work. Not that they get better. Yeah, they get better, but we, like I said, in acute COVID, released a lot of patients who got better who weren't better. And this prolonged therapy, or this prolonged immunology, I think is due to undertreatment in the hospital. And frankly, why are we using steroids when we can use an immune modulator like CCR5 antagonists? What do? They relieve immune T-cell exhaustion. and corticosteroids increase or don't allow for T-cell activation. The most important function of CCR5 antagonists is they repolarize macrophages. So Paul Merrick and I agree, this is a macrophage disease. Macrophages are what's making the cytokine storm, IL-6, TNF-alpha, causing all the tissue damage. Binding an antagonist to CCR5 changes a macrophage from an M2 macrophage, which is a pro-inflammatory macrophage, to an M1, which is an effector macrophage. We don't need steroids. We need immune modulators. And as I've said on many interviews and podcasts, the way to prepare ourselves for emerging infections going forward is to have sequence-agnostic therapeutics. Because for us to come up with therapeutics that are sequence or viral specific takes time. Just like the PD-L1 inhibitors revolutionized cancer therapy, we need to revolutionize emerging infection therapy by using pathogen and sequence-independent therapeutics. That's my message. Thank you very much.
Many thanks, Dr. Patterson. It's a fantastic presentation because it opened a new way, and also with the idea that we have of the fragmentation theory on this virus and the effect of part of the spike protein to simulate immunological response in the interstitial of the tissue. It's a new vision that we have it on that. There is a new pathway on that. Okay. Now I invited Dr. Villa to speak. I'm sorry for the comment, but I wanted to underline this type of job that is very new.
Buon pomeriggio.
Hello, I am Dr. Villa Diaz.
Sorry, excuse me, but I cannot speak good English and I cannot speak good Italiano. So I will speak in español. En primer lugar,
First of all, I would like to thank Senator Roberta Ferraro, who invited me here 3 days ago, saying, Dr. Villa, you have to attend the Rome conference live. It was impossible for me economically, and so we really sacrificed in Paraguay. We established a group called Treating COVID with Ivermectin, azithromycin, C vitamin D3 that's involved in the protocol. Therefore, my patients, about 7 million people from Paraguay, take ivermectin and use my protocol. They gathered the necessary funds, and thanks to them, I am here. I'd also like to thank Magister Angelo Giorgiani, who helped me, and who is here with me, and Coronel Guillermo Tamaño from Corovide, who helped me with the money. As you can see, I am very humble. I'm not well dressed. Here you can see my name on the tag and the flag of my country. And I think that humbleness is very important. And I've learned that Christ preached with a simple clothes and sandals. So humbleness is important for me. In January 2020, in France, 1 month after the beginning of the pandemic, there was a protocol on azithromycin that was supposed to isolate and kill the virus, followed by hydroxychloroquine. In Paraguay, it arrived in March. I'm talking about COVID. And since April, I've been using hydroxychloroquine and azithromycin with good results. As a result, on April the 3rd, Australians discover in vitro that ivermectin works. And since there, in vivo studies begin. And since then, the work of Héctor Carballo, who is now one of my friends, and Dr. Stramezzi. I'm not sure if he's here yet. Oh, yes, and Dr. Stramezzi. I participated in a summit with Dr. Stramezzi here in Rome, and so I'm very happy to be reunited with him here. I am talking in the name of Carballo and others whose papers have been published on The Lancet and consider the reduction of viral charge, of symptoms, and mortality. That study has been published on The Lancet. Carlo Chaculo in Navarra, Pamplona, Spain, publishes a study saying, together with scientists from Spain, Swiss, and Africa, he published a paper saying that ivermectin decreases viral charge of COVID. And then we have Pierre Cori, who published a paper on the US journals. He published his meta-analysis, including 63 RCTs published on the FLCCC Alliance with more than 2,000 papers coming from top-level researchers. And it has been published on the American Journal of Therapeutics. And then we have Israel, which also published good results on ivermectin. I had 60,000 patients here, but this is all craftsmanship. I don't have any stats or data. To treat patients, I created a WhatsApp group of 256 people, and now we have two groups with 12,000 patients. I think that half of Paraguay, about 3 million Paraguayans, are taking ivermectin. And we have been attacked by the government and the Ministry of Health. I was reported by the Ministry of Taxes because I gave 3 tablets of ivermectin to a woman, and her mother got COVID, passed it down to children, and now they are facing the worst comorbidity, obesity. They were taken to the hospital, they were ventilated, and the media said that Dr. Villa poisoned them with ivermectin, and there is no such thing as ivermectin poisoning. Since the 70s, people have been treated with ivermectin. Satoshi talked with Campbell when they discovered an antiparasitic that was top-notch, and since then it has been used. In 2008, it was used for onchocercosis with 130 million patients that only developed a mild headache, which was treated with aspirin. I was accused of poisoning. The diagnosis of this child was severe lateral pneumonia, not poisoning. Anyway, I will talk about ivermectin. And I will also talk about the fact that public healthcare assistance centers were full with 150 victims every day. We were treating people at home with oxygen to keep a 95 saturation. At 94, it was already hypoxemia, and they were given oxygen. They received antibiotics, and after 10 days, the virus was gone. What's left is the anti-inflammatory reaction, the cytokine storm, which kills the patient, and the hypercoagulation state. Our protocol, our treatment that was spread throughout America, in Spain, in Rome, in Buenos Aires, with many patients involved. When saturation reaches 95, the patients receive antibiotics, and we went on by experience. Labs were full, and in my country, which is very poor, I only asked a hemogram, a PCR, to see leukocytosis, which didn't link to any bacteria, by the way. And so there were no mentions of inflammation, and that's why we used dexamethasone. Pierre Corey from the US said that they discovered dexamethasone as useless, basically, but it was already widespread globally. But it was marketed. There was a new drug that was marketed as incredible, and it is involved in a new meta-analysis that has been published. Please, next. There we are. So, since I only have 5 minutes, I will get to the treatment. Here we have the doses, 600 milligrams per pound. If you have a 6 milligram tablet, only one lab used to produce it. Now we have more labs that are manufacturing them. Ivermectin is a miraculous drug. It's effective. This virus links to the cell through the spike attachment, which binds to the ACE2 receptor, and it enters the cytoplasm. And that's where ivermectin acts. It blocks importing. It blocks the channels through which the virus reaches the nucleus. What the drug does is make holes in the binding between the virus and the ACE receptor. Another thing it does is work with platelets. Platelets gather white blood cells to create the clots. So ivermectin has been used to prevent clots, and it has been used for many diseases like Zika or dengue, because it's an anticoagulant product. I have 5 protocols. Prevention every 5 days. Prevention of the contact with mild symptoms. If you are 40 kilograms of weight, this is the dosage, as you can see it here. My magic formula is ivermectin and azithromycin. On January 2020, the virus could already be made alkaline and neutralized. You can give 2 grams, you can give 2,000 units of vitamin C, 7,000 units of vitamin D, and then follow the protocol as displayed here. And then we have the protocol of severe symptoms, when there is a fever already. The virus is gone and there is a bacteria left. I only asked for specific tests like blood counts, and that's how we detected leukocytosis and neutrophilia. Here we have the first antibiotic scheme. Please, the previous slide. 2 grams by day of ceftriaxone, followed by levofloxacin, 750 milligrams, and piperacillin and tazobactam. We used to use the whole vial with 8 milligrams of dexamethasone. And then for a high dosage, 1 milligram for pound or more for each dose in severe cases. And that's how we attack inflammation and clots. Now, oxygen to keep a 95 saturation. We use dexamethasone, enoxaparin, and other drugs that are anti-inflammatory and anti-clotting, like ivermectin for sure. And now I'm about to conclude. The ivermectin treatment, less time of PCR negativization, less time of recoveries, more recovery rate, a higher survival rate. These are evidence about ivermectin. And before I conclude, Dr. Hector Carballo, we talk every week. He couldn't attend today due to personal issues. He considers me as one of the Latin Americans who worked in the best way, and that's why my patients provided for my trip here in Italy. I'm not sure if you can hear the audio from Professor Hector Carballo. In the following slide, you will hear his voice, and with this audio from Hector Carballo, I will conclude my remark. Let's see if we can hear Dr. Carballo. I think that if you push on the audio sign, it will work. Hector Carballo said, I want to congratulate you for the amazing job you did and you continue to carry out against the pandemic. To me, it's an honor to work at your side. And please tell me when you're going to present the results you mentioned yesterday, which had a great impact for all of us, because I would like to get up and applaud you, even though it will be virtually. A big hug from Hector. The Paraguay Ministry of Health wanted to arrest me, while Carvalho says I deserve to be applauded for my work. I decided to get out of my comfort zone. The Paraguay Ministry of Health says that the asymptomatic phase and the mild phase can be solved through paracetamol, ibuprofen, but that's just nonsense. I attack the virus with ivermectin, with direct intervention in the throat and in the nose. I don't want the development to get severe. I want to treat patients early. With this, I conclude. Enjoy the rest of the afternoon.
I invite now Dr. Francesco Matozza. Matozza is there? I remember that I think that we have 6 p.m. That is the limit after we can be tolerated.
Yes, Dr. Matozza asked me to introduce him, and I do it very gladly because he's a doctor just like the others. He cured 200 patients, but he has a peculiarity, meaning that he is he has studied political science, and he is responsible for the Italian consulate for medicine and psychology and the Italian embassy in Paris, and he cured 200 people remotely with the drugs that we use. This is the only embassy that has done home therapies. Good afternoon, Senator Roberta Ferrero, dear colleagues, ladies and gentlemen. For me, it is a pleasure to illustrate the consequences of the pandemic. The home therapy, it's something that we have developed together with Dr. Carvalho and Robert Hirsch, who was the director of the infective diseases department in Buenos Aires. We have used home therapies with the IDEA protocol by Dr. Carvalho. We've used it since October with the first patients. We've used this protocol, and then we use azithromycin, vitamin C, vitamin D, and then we also added dexamethasone, enoxaparin, and heparin. And on these patients, we only had 8 hospitalizations, and we only had 3 patients whose families contacted us once they were hospitalized, among which we can find an 85-year-old in the American hospital in Paris who had many other issues and complications and an infection, and who completely recovered. She's still alive today. Many colleagues have already spoke about these drugs, so I would like to talk about the costs. The weekly cost of therapies without enoxaparin is about 130 euros per week. with enoxaparin is around 600 euros. With these protocols, we treated more than 50,000 patients in Argentina and 90 in Paris. So what are the costs of hospitalizations? These are the costs from public health in Paris, because in private hospitals, the cost is much higher. So we have a moderate COVID, meaning 7 days in a normal hospital floor at 9,795 euros, whereas in 14 days in the ICU is more than 68,000 euros. With severe COVID with 30 days in the ICU, it's 147,000 euros. And then we also have to add SSR, what is called in French SSR, meaning physiotherapy of patients, because many patients have difficulty moving after 2 months in the ICU, and these are an additional 15,000 euros. What we saw with home early treatment, with the IDEA protocol and others, is that we can reduce the cost and hospitalization by more than 90%. And this is particularly important as far as economics go, because with just 130 euros per day, we reduce hospitalizations a lot. And then we have more free beds for other patients, for example, neurological and oncological patients, patients who need to be at the hospital and who need to be in the ICU. And then the other thing is years lost to COVID. According to a study by a university in Barcelona, who studied 81 countries, the number of years lost, meaning the life expectancy and death, in the countries particularly hit by the pandemic, that can go from about 9 times the years lost due to a seasonal flu. More than 85% of years lost due to cardiac pathology. In Italy, we lost in 2020 about 20 million years. And due to COVID, in the 81 countries studied in Barcelona, it's 16 years for each individual patient. I've had some very severe patients at 30 years, meaning that that person could have lost 50 years. And then we also have the years lost by the family, meaning orphan sons and a widowed wife. And these are all the consequences that are incommensurable as far as economic damages, such as, for example, the reduction of life expectancy or productivity, or not going to work and not wanting to move to different countries where there are no hospital or clinics. So these people might want to work from home. And then we have the physical consequences, meaning the loss of smell and taste in the short term. I still have patients who still don't have these back, and they're doing experimental therapies. And then we have a lack of movement that can cause many problems at a respiratory level, meaning that patients in the ICU have pulmonary fibrosis, and so they need oxygen. And then we have psychological consequences, meaning an increase of violence, a decrease of empathy among people, and an increase in suicides that I've seen in France, for example. So, to conclude, I would say that we need early home therapies to all of the patients to avoid hospitalization. We need a prophylaxis for the families since the beginning, meaning that a patient that lives with the family, the wife and the sons, all of them need to have ivermectin and not to get the result of the test to say whether they're positive or not. Recently, I had a family, a father and 2 kids who went to Euro Disney. The father is sick, and I gave ivermectin to the sons and to the father, and now, 8 days after, the father is negative, meaning that they all can come back to Italy. And this is one of the most important advantages, economical advantages, meaning that they don't have to pay any time longer to stay in France. So we need to be in the front line for our COVID patients and give them all of the tools necessary to have great home therapies. And this also brings to a decrease of costs. And we should not postpone important surgeries due to a lack of ICU beds.